So hello and welcome to this microbiology podcast, which is going to be an introduction to gram-positive bacteria. My name's Ed Wallet, and today I'm joined by a final year student from Imperial called James Wigley. Welcome.
Well, thanks Ed for having me on. I think we're going to do two podcasts, one on gram-positive, one on gram-negative. Let's dive right in.
Let's get on with it. So this is a book that you did quite a lot of reading from, I think, when you made these slides. Isn't that right?
Yeah, it really is a good book. I'd recommend it to anyone. It makes the quite dull subject of microbiology, in my opinion, far easier to read than the stuff I've read in the past.
Yeah, more accessible, I think. Quite detailed though. It's quite a detailed book.
Yeah, it's good to flip around in though.
Yeah, cool. So this is basically what we're going to talk about. We're going to start with a bit of a classification. We're going to classify the bugs according to their shapes, according to various virulence factors. We're then going to talk a little bit about how the bugs are named, then go on to talk about gram-positives in this podcast, and then in a podcast for next week, we're going to talk a little bit about gram-negative bacteria, mycobacteria, and mycoplasma. So, tell us about gram staining.
Well, the reason we gram stain is to give us an idea on the class of the bacteria. Are they gram-positive or gram-negative? And an easy way I find to remember this is the phrase, "I'm positively blue for you." Now, obviously that's gram-positive bacteria stained blue, and the gram-negative ones stained red. Cool.
So important differences between gram-positives and gram-negatives. This is quite a good overview, I think. Do you want to go through that?
Yeah, and this is, I've struggled to get my head around this, but fundamentally you've got gram-positive bacteria have a cell wall that contains extensive cross-linking of peptidoglycan and teichoic acid, which is a polysaccharide. Gram-negative bacteria, on the other hand, contain a peptidoglycan cell wall, but it's very thin. So the gram-negative bacteria are unique in that they contain an outer layer of lipopolysaccharide, otherwise known as LPS. Now inside that LPS exterior is lipid A, which is also known as endotoxin. And when the bacterium is phagocytosed, lipid A is released, inducing fever, diarrhea, and can lead to septic shock.
Okay, but that doesn't mean that gram-positives can't cause septic shock. Is that right?
No, it's a different pathogenesis with gram-positive bacteria.
Okay, cool.
So, importantly though, you must remember that endotoxin is a structural component of the outer membrane of gram-negative bacterium. Endotoxins differ from exotoxins in that it's not a protein excreted by the bacterium, rather a normal part of the membrane that sheds off, especially during lysis.
So there are basically three types of toxins that bugs produce. There are exotoxins, neurotoxins, and enterotoxins. Exotoxins are essentially proteins that are released by all major gram-positive and gram-negative bacteria, except for Listeria. Neurotoxins are a type of exotoxin that have a particular action on nerves and motor end plates, and the two that most people will be familiar with will be tetanus and botulinum. Enterotoxins, on the other hand, are exotoxins that act on the GI tract and cause diarrhea by essentially reducing absorption of salts, particularly sodium chloride. Bacteria grow and release enterotoxin into the food, and enterotoxin tends to cause diarrhea and vomiting for less than 24 hours. Contrast this, on the other hand, to infective diarrhea, where there is actual bacterial colonization within the GI tract.
Okay, so let's briefly look at cell structures and virulence factors. Now, there are various virulence factors, but here we're just going to talk about the major ones. You can have flagella. An example of this would be Vibrio cholera or E. coli. You can have pili, which protect the bacterium against antibodies, and Neisseria gonorrhea uses this to good effect. You can also have a capsule surrounding the bacteria, and examples of this would be Haemophilus influenzae and Strep pneumo. Ed, why is that important?
That's particularly important because in patients who are asplenic, i.e. patients who don't have a spleen secondary to trauma or a primary hematological condition, they're at particular risk of developing encapsulated infections. And the two listed here, of course, are Haemophilus influenzae and Streptococcus pneumoniae. Haemophilus influenzae, importantly, causes epiglottitis, and Streptococcus pneumoniae is an important bug in the pathogenesis of pneumonia and also meningitis.
Yeah, I think that's about it, isn't it?
I hope so.
So, endospores is the fourth one on this list. Now, this is used by Bacillus and Clostridium, and I think we're going to cover that later when we talk about Clostridium difficile. And also, the last one we have here is facultative intracellular organisms, which actually are crafty in that they survive within phagocytes. Examples being Listeria, Salmonella typhi, Legionella, and Mycobacterium.
Cool. So now we're going to move on to the kind of overview section of the podcast. Think of bacteria as having four possible shapes. They can be spherical, in which case they're called cocci. They can be rod-shaped, in which case they're called bacilli. They can be spirals, in which case they're called spirochetes. And they can take any type of form, in which case they're termed pleomorphic.
Okay, so the good thing to know is that there are really only 6 gram-positive bacteria that are pathogenic. And these can be broken down into those that have a cocci shape, those that are rod-shaped and form spores, and those that are rod-shaped and don't form spores. So in the group of cocci-shaped bacteria, we have Streptococcus, which a good way of remembering that is that they form in strips, so with a hard P. You have Staphlococus, which form in clusters. Moving on to the second grouping, really, those spore-forming rods, you have Bacillus and Clostridium. And last but not least, we have the rod non-spore-forming bacterium, which is Corynebacterium, which you may not have heard of in that name, but causes the disease diphtheria. And finally, Listeria.
Cool, but there are some exceptions, aren't there?
As with all things in medicine. Mycobacteria is a weakly gram-positive bacterium, but we use a different stain. I think it's acid-fast.
Yeah.
There's another couple of names for that staining. And there's also Mycoplasma, which doesn't have a cell wall, of course. So we can't use the gram-positive or gram-negative kind of classification. But all the others are gram-negative bacteria.
Yeah, so the acid-fast bacilli, when you see acid-fast bacilli referred to, you're thinking of mycobacteria, usually tuberculosis, that will be, or Mycoplasma tuberculosis.
Okay, there we have the list. Let's dive straight in and get on with Streptococcus. Okay, so how do you differentiate between staph and strep? Well, you can't do it clinically. But under the microscope, you can see that Streptococcus forms in strips, as we said, and is catalase negative, and Staphylococcus forms in clusters and is catalase positive. Okay, now there are 5 significant streptococcal pathogens, and they are classified under the Lansfield classification. Not that you need to know that, but there are different forms, namely Group A, Group B, Group D, which is also known as Enterococcus, Streptococcus pneumoniae, of course, and the Viridans group, Streptococcal. Of course, the last two not strictly being under the Lansfield classification.
Cool. So I'm going to talk a little bit about Group A Streptococcus. Another name for this is Streptococcus pyogenes, and pyogenes refers to the pus-producing characteristics of this particular bug. So this produces a variety of clinical syndromes. Most commonly, it causes strep throat, and this is known as streptococcal pharyngitis. It can also cause skin infections, particularly in patients who have eczema, and therefore have a weak barrier to this type of infection. It can also cause scarlet fever that manifests as a red rash, typically sparing the face, and looks a little bit like sandpaper clinically.
Yeah, I think we're going to cover that later, aren't we?
Yeah, I hope so, yeah. So, and then lastly, streptococcal toxic shock syndrome, which we'll talk about in a bit as well, I think.
There are also a couple of delayed antibody-mediated diseases, aren't there, Ed?
Yeah, rheumatic fever. This is very important, and most important, you shouldn't regard rheumatic fever as an infection. It's actually almost an autoimmune phenomenon where there's cross-reactivity between antibodies directed at the infective organism and at various tissues, importantly joints, heart, kidneys, etc. And the other type is glomerular nephritis, and I don't think we want to get bogged down, particularly in autoimmune nephritis. But it's important to be aware that these two conditions are not directly due to infection, but a kind of autoimmune phenomenon.
Couldn't agree more. It's complicated stuff, that. Okay, so group B Streptococcus. Remember, think B for baby. These bugs cause meningitis, of course, sepsis, and pneumonia. So Ed, just briefly tell us, what organisms would you cover if you suspected a neonatal meningitis?
Well, you have quite a few actually, and importantly, they're very different to the types of organisms that typically cause meningitis in young adults. In young adults, you're thinking, of course, about Neisseria meningitis, particularly type C Neisseria meningitis. But in neonatal meningitis, you need to think about the bowel organism E. coli, you need to think about Listeria, and also, of course, what we're talking about, group B Streptococcus.
Okay, now we've done group A and B. We're going to miss out group C because I don't think I've ever heard of it.
No, it doesn't exist.
Okay, very cool. Could they not spell?
Obviously not.
Mr. Lansfield. Okay. Right, so group D Streptococcus has two forms, enterococci, which makes up a large proportion of normal bowel flora, and non-enterococci. Okay, so enterococci is a common infective agent in UTIs, biliary tract infections, bacteremia, and subacute bacterial endocarditis. Importantly, though, remember that group D Streptococcus preys on weakened hospitalized patients. So people that you're going to come across on the wards, so keep it at the back of your mind.
Yeah, and also actually there's quite an interesting association between non-enterococci or non-group D Streptococcus and colon cancer.
Okay, do you want me to talk about strep pneumo?
Yeah, go for it.
Okay, strep pneumo, aka pneumococcus. There are a lot of AKAs in this podcast. I do apologise. It's just the way microbiology is. A good phrase for strep pneumoniae is pneumococcus is to parents what strep B is to babies. So this is the most common cause of pneumonia and meningitis in adults, and it's also the most common cause of otitis media in children. Now, as Ed mentioned before, with regard to capsulated organisms, you must vaccinate immunocompromised patients with Pneumovax to protect them against strep pneumo.
So yeah, patients say with no spleen or with retroviral disease.
Okay, finally, we have Viridans group Streptococcus, and that causes three types of infection. Dental infections, although I think these are getting far less common now due to better dental practices. It also causes abscesses, particularly sites include the brain and the abdomen.
Yep.
So now we've tackled one half of the gram-positive bacteria that are cocci. Let's tackle the other half, being Staphylococcus.
Cool. So staph is an exceedingly common infection and can actually affect any organ system. You can divide them into, or you can divide the diseases into those caused by exotoxin release or that caused by direct invasion. The important conditions caused by exotoxin release are scalded skin syndrome, gastroenteritis, and toxic shock syndrome. Importantly, gastroenteritis or Staphylococcus-related gastroenteritis is really the most important infection that causes the onset of vomiting within 24 hours. The disease resulting from direct invasion include things like skin infections. Once again, this is very common in patients with eczema, who will often get a mixed staphylococcal and streptococcal superinfection, which is termed impetigo. Acute bacterial endocarditis. Staphlococcal acute bacterial endocarditis is particularly nasty and tends to destroy valves very, very quickly.
It's far worse than a strep bacterial endocarditis, isn't it?
Yeah, really nasty, really nasty. And importantly, it tends to affect the right-sided valves of the heart. And the reason for that is the entry point usually for Staphylococcus and endocarditis is through IV drug use. And most IV drug users inject into veins, so of course...
Don't do it.
It goes straight to that side. Don't do it, no.
Nasty.
Osteomyelitis, obviously is an infection of the bone, usually occurs in young kids, less than 12, and spreads to bone hematogenously. Importantly, it presents with warm, swollen tissue over the affected bone, systemic fevers, and often the limp. Pneumonia as well can be caused by Staphylococcus, and once again, Staphylococcal pneumonia is particularly nasty and particularly tends to be quite pussy. So if you get empyemas, and you can get abscesses formed with that. Staphylococcal meningitis can also occur, and also, of course, just like osteomyelitis, you can also get a septic arthritis with Staphylococcus.
Right, okay. Toxic shock. Now, this classically presents with a lost tampon and often comes up in the EMQs that way. Causes the release of TSST1, which I think stands for toxic shock syndrome toxin 1. It's an exotoxin that we alluded to earlier. Try and think of this as a combination of scarlet fever and food poisoning. On the scarlet fever type of symptoms, you get a diffuse erythematous rash, desquamation of the palms and the soles, and also septic shock. Enterotoxin-like symptoms include fever and DNV, of course.
This is actually becoming quite rare to see in the emergency department now, because a lot of patients, because of the publicity of this condition on casualty and ER and stuff like that, are actually, as soon as they lose their tampon, they come in before they actually display any of these symptoms. But that's a really disgusting aside. So
yeah, it's a good thing.
So we'll move on. Yeah,
quickly. Now, scalded skin syndrome. This is, once you see this, you'll never forget it. It's, as you see, we've got a nice photo here that's stolen off Google, as per usual. But it's caused by a production of an exfoliation toxin. Usually affects neonates and causes cleavage of the middle dermis. So the skin peels off to reveal an erythematous base, but it's got moist skin below. And thankfully, although it looks absolutely dreadful, healing is rapid and the mortality is actually very good.
But these patients still require support, particularly for fluid loss, which can be quite extensive, and also heat loss as well.
Absolutely. Can you say mortality is good, or is it mortality is low?
Mortality is good is probably a wrong way of saying it, really, isn't it?
My mistake. Yes. Okay. Ed, tell us about acute endocarditis.
So we've spoken a little bit about acute endocarditis already. It's quite a destructive infection, and particularly destructive to the valves. It tends to present with very high fevers that may be high enough to cause severe myalgia, rigors, chills, very severe headaches. Most patients who develop acute endocarditis tend to develop it on the background of valve dysfunction. When this happens, it's usually caused by streptococcus that usually gains access through a trivial wound or through a dental procedure, and then colonizes the valve. However, some people have no history of valvular disease and develop acute endocarditis. And as I mentioned earlier, this tends to be IV drug users who get staphylococcal infection on the valves on the right side of the heart. Vegetations grow quite rapidly on the valves, and importantly, you can get embolic abscesses either in the lungs if the bugs are on the right side, and the brain if they're on the left. Importantly, remember though that endocarditis caused by strep has a much more gradual or insidious onset compared to that caused by staph. Okay,
Ed mentioned this earlier, staphylococcal skin infections. Just briefly though, you get minor skin infections caused by either staph or strep pyogenes, but they can manifest in a number of guises, namely impetigo, cellulitis. You can get a local abscess or indeed a wound infection. Quite commonly, though, they're the result of a bladder and catheter infection. Remember, though, it's clinically impossible to differentiate between group A strep and Staph aureus.
Yeah, and that's the reason why most of these infections you use actually two different agents.
Yeah.
So you'll use benzyl penicillin and flucloxacillin to cover both.
Okay, so we're doing well. We've left to do the spore formers and the non-spore formers. Okay, so spore forming rods. These can be separated into bacillus, which is an aerobic gram-positive bacterium, and clostridium, which is an anaerobic bacterium. Think of this as clostridium. Think airtight closet.
Nice.
Now, thank you. I don't think it's mine though.
Don't own up to that on the podcast.
We'll cut that.
Too late.
There are two types: Bacillus anthracis, which causes anthrax, and Bacillus cereus, which causes gastroenteritis. Now that commonly comes up in your EMQs as a student presents with diarrhea and vomiting following a meal of a Chinese takeaway the preceding night.
Yeah, usually it can sometimes be the following day, because the conditions under which Bacillus cereus really thrives is when, for example, there's some rice from your Chinese takeaway and you leave it out overnight and then eat it the next day. That's really the characteristic picture and history from these patients. Unfortunately, a lot of Chinese takeaways, they just reheat the rice that's been standing around anyway. So you get it both ways, I suppose.
Let's hope no Chinese takeaways are listening to this, as are the dentists. Okay.
No Chinese takeaways are listening to this. Yeah.
No,
this is very popular in the Chinese community, actually, this podcast.
Maybe, it's on iTunes.
Yeah.
Okay, so let's get back to it. Clostridium. I've said it's anaerobic, and it causes a few actual different diseases. Botulism, tetanus, gas gangrene, and, of course, pseudomembranous colitis. So let's talk about these in a bit more detail.
So Clostridium botulinum is one of those bugs that we talked about earlier that releases a type of exotoxin known as a neurotoxin. This particular neurotoxin blocks the acetylcholine at the presynaptic nerve terminal and leads to a flaccid paralysis. Clostridium tetani, on the other hand, ultimately causes a sustained tetany, particularly in the jaw. It's found in soil and animal feces, and is known to germinate in an anaerobic environment, particularly necrotic tissue.
Yeah, absolutely. So if you have a puncture wound, when you go to the emergency department, you'll be given a booster of tetanus to prevent against getting Clostridium tetani.
Unless you've already had 5.
Well, of course.
In which case you won't.
Okay, and finally the third disease, which is Clostridium difficile.
Big one, this one.
Yeah, absolutely, aka pseudomembranous enterocolitis. Now, of course, you'll know that this follows the use of broad-spectrum antibiotics. It releases 2 exotoxins, at least I think it does. There's type A, which causes diarrhea, and there's type B, which is cytotoxic to colonic cells. Importantly, though, remember these are bacteria that form spores, and if you see a patient with C. diff, it's important not to wash your hands with the alcohol gel, but to make sure you thoroughly wash your hands with soap and water.
Yeah,
because that's the only way it's gonna.
And obviously, this is a huge problem in hospitals at the moment, particularly with the use of broad spectrum antibiotics, particularly the cephalosporins, and that's the reason often that the patients who develop diarrhea within hospital are often immediately put in a side room to prevent the spores spreading.
Yeah, absolutely. Ed, just tell the listeners why it's called pseudomembranous colitis.
It's basically because the production of toxin B, which is cytotoxic, causes necrosis of the epithelium that results in the formation of pseudomembranes. And although this can be suspected by the presence of, say, dilatation on an abdominal radiograph, definitive diagnosis of pseudomembranous enterocolitis can only be made actually at colonoscopy under direct vision.
Very good. Okay, finally, we come to the non-spore formers. This encompasses 2 bacteria. Corynebacterium diphtheria, we'll talk about first. That actually colonizes the pharynx, and you don't generally see it these days because we're all immunized against it, or at least should be. But if you do see it, you'll see a greyish pseudomembrane at the back of the throat, and it's very important not to go and poke and prod that, because if you do, you can knock that pseudomembrane off and release bacteria into the bloodstream, and it can be very, very nasty indeed, damaging the heart and the neurons.
Yeah, and there's another infection as well that you shouldn't go poking around in the throat in. That's epiglottitis, caused by
Haemophilus influenzae.
Haemophilus influenzae. And the problem there is that if you go poking around in that situation, you can actually cause airway obstruction. Yeah.
Okay, so Listeria monocytogenes, another EMQ classic, often affects, or I say often, in the EMQs at least, it will often affect pregnant ladies that have a fetish for French smelly cheeses. It's actually the third most common cause of neonatal meningitis behind E. coli and group B strep.
Yep, B for babies.
Yeah, absolutely. But Listeria, remember, it's the exception to the rule. It's a gram-positive motile rod that actually has an endotoxin, unlike all the other gram-positive bacteria.
Cool. So that's it. We've covered everything for those gram-positives. Talked a little bit about the classification. We talked a little bit about what makes each bug different with respect to its shape, with respect to the various virulence factors that are present. We talked about how to name the different bugs. And then finally, we've gone through a few individual gram-positive bacteria and talked a little bit about some important clinical examples. So, thanks for coming, James.
Well, Ed, thanks. It's been interesting.
It's been good. It's been good fun. As always, if you have any questions, please don't hesitate to contact us at feedback@podmedics.co.uk, and we hope to see you soon. So it's goodbye from Ed.
And goodbye from James.